This is a systematic review on management of displaced olecranon fractures in the elderly. And we also proposed a treatment algorithm. This is the outline of my presentation. So olecranon fractures are very common in elderly, 40% of proximal ulnar fractures and almost 10% of adult upper extremity fractures are olecranon fractures. Challenges are the bones are very osteoporotic, comorbidities, soft tissue compromise, and post-operative complications. Surgical fixation must be balanced against a variety of factors. Treatment options are non-operative. We have limited fixations like tension band wire and cerclage wires using absorbable materials, and operative fixation, that is metallic tension band wiring or plate fixations. There's no current consensus on optimal management. We used a systematic review following PRISMA guidelines. Our population was more than 60 years with the olecranon fractures. Interventions, as mentioned, was non-operative, limited fixation, and operative fixation. We had 19 studies with the 710 patients. Majority of them were prospective and retrospective studies. One was randomized controlled trial. This is the search strategy. Treatment distribution, we had 257 cases in non-operative, 179 in limited fixation, and 276 in operative fixations. We use the functional outcomes, DASH and the quick DASH, and also the Mayo elbow performance score, a range of motion, and union and complications. So coming to the non-operative management, we had 11 studies reporting outcomes of non-operative treatment. Their DASH and MEPS scores showed that they had only mild disability and good to excellent function. Most patients regained functional arc of motion around 120 to 140 degree. They had a small extension lag of -7 to -10 degree. All the non-operated patients had good functional outcome in spite of radiological non-union. Limited fixation using absorbable materials like tension band wires and cerclage fixation. Their outcome was also good considering the quick DASH and DASH values, as well as the range of motion arc was 120 to 136 degrees. Unlike the non-operative group, they had a stable, the fracture was stabilized, and also fewer reoperations was seen with cerclage fixation compared to tension band wiring using absorbable materials. Coming to the operative fixation, the striking part was they all had high complications and reoperation rate, almost 30 patients. Plating gave better stability and union, but wound issues were around 2 to 5%. So union rates exceeded almost 90% for all the plating techniques. To summarize, the three non-operative management produces acceptable functional recovery in elderly, low demand patients with Mayo type 1 and 2 fractures, despite frequent radiographic non-unions. Limited fixations give fracture stability and also a good functional outcome, and suggesting a viable compromise between the stability and morbidity. Operative fixation was most beneficial in unstable fractures, something like Mayo type 3, but reoperations were at a high rate. When you consider the complications, we can compare non-operative had very few complications compared to the operative. And even though non-operative had almost 80% of non-union, they all returned to their normal activities. By fixation method, tension band wiring had most of the complication compared to the plating and limited fixations. To discuss, elderly tolerate non-union well. Limited fixation reduce hardware issues, and metallic fixations like plating and tension band wirings has high reoperation rate. So we need to consider stability, bone and soft tissues, and patient demand before considering what treatment to be given. We do propose a algorithm when there is an elderly patient with displaced olecranon fractures. We need to assess the elbow stability. If this is a stable elbow, a low demand patient, non-operative or a limited fixation could be an option. If it's a high demand, then limited or a plate or a metallic fixation is suggested. If it is an unstable elbow, if it's a good bone and soft tissues, we could do a plate fixation. If it's a poor bone or soft tissues, then a minimal limited fixation, and we need to address the stability. To conclude, treatment must be individualized based on elbow stability, functional demand, and bone quality in elderly patients. Non-operative management is well tolerated in spite of significant amount of radiological non-union. Limited fixation is safe and preserves function. Metallic fixation plates and tension band wires give high complication and reoperation rates. When surgery is indicated, weigh the risk versus functional benefits carefully. We do had limitation in our study. Only one RCT was available, and there's a different definition of elderly, hard to generalize results, and treatment approaches and patient factors vary risk of bias, and it's best to tailor the treatment to each patient. Thank you.